Hey, good afternoon, everyone. Before we get started, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. We're very fortunate to have a visiting professor for our medical grand rounds today, and I'd like to invite the Chief of the Division of Endocrinology, Dr. George Fantas, to introduce our speaker. Thank you, George.
Thank you, Nadia. So it's a pleasure for me today to introduce our visiting guest speaker, Dr. Gabbay. Bob, the most important part of the introduction is that he is a McGill graduate from biochemistry. I won't tell you the date. He went on after his undergrad to the University of Wisconsin in Madison to do a PhD, and then realized he liked medicine and went to State University of New York to complete his MD. He did his internal medicine training at Cornell in New York City, and then moved to Boston, to Harvard and MIT to complete his endocrinology and metabolism subspecialty. He was recruited to Penn State. Important point there is that it's near Hershey, where the chocolate factory is. So I think he was well suited for diabetes career. At Penn State, he actually developed a diabetes center, which morphed under his leadership into a diabetes institute. He was recruited back to Harvard in 2013 to become chief medical officer and currently vice president of the Joslin Diabetes Center, and works at the Joslin and Beth Israel Deaconess Medical Center. Around the 2010 mark, he became active in the American Diabetes Association, joining the Guidelines Committee. And his valuable contributions, his leadership in organizing the annual scientific meetings, and clinical research experience led the ADA to appoint him as Chief Scientific and Medical Officer. He's led or participated in 55 clinical research projects, ranging from pharmaceutical trials, diabetes technology, innovations, health equity, innovations, and health outcomes. He's collaborated with industry and governments. He's published over 150 peer-reviewed papers and served on multiple editorial boards and editor at 9 journals, and reviewer for many granting agencies, and of course trained many students and fellows. It should be noted, while he was at the ADA, Dr. Gabbay led many transformational initiatives, including establishment of the Primary Care Council, and led the US development around patient-centered medical home, which is for primary care practitioners. He reinvigorated the standards of care guidelines by the American Diabetes Association, the leading guidelines in the world for diabetes, and expanded the diabetes prevention program through a multi-year $12.5 million grant from the Centers for Disease Control. He's launched the Institute of Learning and established the Leapfrog initiative to recognize quality of care in diabetes in the hospital, and founded the ADA's Innovation Challenge program. So it's really a pleasure to welcome Dr. Gabbay back to McGill, his alma mater, and today he's going to be telling us about improving diabetes care. Welcome, Dr. Gabbay.
Thank you so much, and thank you, George, for that generous introduction. I wish my mom was here in the audience to appreciate it. Here are my disclosures, and just a little bit about me in pictorial form, and Dr. Fantas did a great job of summarizing a lot of it, and traveled many paths, and I stepped down from my role at the American Diabetes Association about 3 weeks ago. So this is one of my first presentations post ADA. As George said, this being here has special meaning for me, being a McGill alumni, and they're very fond memories. And I will show you a scary picture of me at graduation. So it was many moons ago. And really, I have such, cherished memories of being at McGill, and walking around yesterday brought many of those back. So thank you for the opportunity to be here. It's very meaningful for me. So what I'm going to talk about is how to drive better care, and in many ways, this, the pathway that I'll describe towards the end really could be applied to a lot of chronic illnesses, but I'm going to obviously focus on diabetes, and typically the challenge is sort of assembling and assimilating knowledge, but then ultimately moving that knowledge to action, and I'll talk about that. I'll start really with a focus on the knowledge side and ensure that we're sort of all up to date on the latest things that are happening in diabetes. Then I'll talk about work being done to move that into action. So, and really, I'm going to center my talk on these set of guidelines, the standards of care in diabetes. They're the most widely recognized guidelines for diabetes, accessed 3 million times a year. I'll tell you a little bit about what this document is, how it's created, and then we'll talk about the specific new things that are contained in it this year. So this is a 300 some odd page yearly document. It, in essence, is a textbook around diabetes. It starts each year shortly after publication to a review of the literature of all the clinical studies that have been done the year before. Take that information, compare it to all of the recommendations that are in the guidelines, and then brought to this incredible group called the Professional Practice Committee. This is a group of individuals that are not only endocrinologists, but primary care providers, nurse educators, dietitians, cardiologists, behavioral health people, really sort of the breadth of the diabetes ecosystem. And they go through this interesting process of debate, discussion, and at times heated arguments until they reach a consensus. And that consensus is then brought to the ADA board for approval, and then published. And one of the things we realized a few years ago was, even though this is published on a yearly basis, there's so much that has been happening in the world of diabetes that we've created living standards where we can add new things in between those yearly publications of that 300 odd page document. And this is all done independent of any external funding. It's all out of the ADA's funding, so no industry sort of influence. This gives you a sense of the members of the Professional Practice Committee and the institutions that they come from, really a wide breadth. And soon I hope to see McGill up here as another representative. And over the last 2 or 3 years, we've added a new step of this where although we have this group of 21 individuals that are quite knowledgeable about all aspects of diabetes, we realize that for certain topics, there's a depth of knowledge needed. And so we bring in external experts to cover one specific area and sort of look at that. So that's the this other group that is part of it. So it really does take a village to produce this thing. It's available free online, and here's the website, and feel free to take a quick photo of it. There's also an abridged version that targets primary care that is shorter, more infographics. They're also a wonderful app, and if I would recommend one thing, it would be to download that app. You then have it on your phone, and I've used it many times in the exam room to look something quick up around one of the potential recommendations. And most all of the figures that I'll show you during the course of the talk are all in that downloadable app as well. And again, free for access for you. So again, how am I going to, cover 300 pages in the next, few minutes? I'm really going to focus on what's new, and I'm going to talk about 4 themes that represent that. So the first is what's new in the world of screening, and there is a fair amount there I'll talk about. The second is around cardiovascular disease risk reduction. And as you know, the number one cause of death for people with diabetes is cardiovascular disease. So that's a very important area. Then obesity, which if you haven't been watching in the news, it's having a moment in our society and has become a really interesting and exciting area, and talk about new recommendations there. And then finally, something that continues to evolve each year, and that's technology. So I'll talk on those four different areas. What you can see here, I'll show these sort of placards, and they represent the section within the standards of care if you wanted to go back and read more of the details. So the standards of care have a series, just if you haven't seen it, it's a series of recommendations. And then there's all of the literature that supports it, highly referenced, all the clinical trials. So again, for house staff and others, this is a great resource for you. So what's new in sort of diagnosis and screening? And the first is around screening for type 1 diabetes. We can now screen for pre-symptomatic type 1 diabetes, and we'll talk in a moment about why you might want to do that, in part because there are now therapeutic options that are available and FDA approved in the US and under review here in Canada. And so there are three antibodies to look at: anti-GAD antibody, islet antigen 2, and zinc transporter 8. Those three antibodies are the things that you can order to be able to screen individuals. And if individuals are positive for multiple antibodies, 2 or more, you have a really high likelihood of developing somewhere of the 75 to 80% will ultimately develop at some point type 1 diabetes. So they're really good at predictive of high risk individuals. And the first step, if someone has multiple antibodies, is to help stage them. And I'll talk about the stages in a moment, but it's essentially based on, do they have any dysglycemia, any abnormal glucose value? And then really, once you've done that, they're probably best cared for in terms of preventative strategies that I'll talk about in a moment in a specialized center. Here are the 3 stages of type 1 diabetes. And this is relatively new, so important for people to be familiar. So stage 1 is having multiple antibodies, as I described, but normal blood glucose. And again, as I said, most of those people over their lifetime will ultimately develop type 1. The area we're most interested are those with stage 2, where they have multiple antibodies, but they also have some dysglycemia. And you can see the cutoffs of glucose values here. And essentially, they're the same as what we would think in type 2 diabetes or prediabetes. So they have some dysglycemia, but not frank diabetes. And the reason it's important to recognize these people is twofold. One, potential therapeutic options for them. And 2, these individuals will move into frank type 1 diabetes in a much shorter time frame. And it's been shown that if you provide them with the appropriate education on what to look for, you can prevent them from entering diabetic ketoacidosis and being hospitalized. So that's stage 2, dysglycemia and positive antibodies. And stage 3 is frank diabetes. That's what we're all familiar with. So again, a staging process. And the recommendation is teplizumab, which, as I mentioned, is FDA approved for individuals 8 years and older to prevent and largely delay the development of diabetes on average, 2 to 3 years, although some have seen even more pronounced effects. There's always been this debate of, well, 2 or 3 years of not having type 1 diabetes, is that really worth it? And all I would say is ask any person living with diabetes or any parent of a child with type 1 diabetes, and I think the answer is pretty clear. So also there's information on, so this is a common clinical situation of someone presents with diabetes. Do they have type 2 or type 1? And how do you go about that? And this algorithm that's also present in the app is a nice way to think of this. So first one thinks about, do they have features to suggest that they might have type 1 diabetes? And probably the biggest one is to think about if they tend to be thinner. Really, for the house staff, anyone thinner that presents with diabetes, think type 1 diabetes right off the bat, regardless of age. So you can see there's an age cutoff of less than 35 or greater than 35. We know that many people are diagnosed with type 1 diabetes over the age of 35. So age is not a determining factor, but it does express some set of risk. So if you think they might have type 1 diabetes, get those antibodies that I described. If those antibodies are positive, yep, they likely have type 1 diabetes. If they're negative, up to 10% of people with type 1 may have negative antibodies. So now it's really thinking about age. If they are younger and they have features, then you want to see what's their insulin secretion as measured by C-peptide. If it is low, they likely have type 1 diabetes. If it is not low, they have a strong family history, they may have one of the monogenic forms of diabetes, maturity onset of diabetes of youth, and those might be people that you ultimately do genetic testing for. So a good way of differentiating type 1 versus type 2. In the screening area, another important thing, and this is particularly applicable for those of you that care for people with pancreatitis, the recommendations now are after an acute episode of pancreatitis, they should be screened 3 to 6 months later for the development of diabetes. And anyone with chronic pancreatitis should be screened on a yearly basis. The simplest way to do this, of course, is with an A1C test. This other area has really emerged over the last few years, and that's the presence of cystic fibrosis-related diabetes. Fortunately, people with cystic fibrosis are living much longer now. As a result, they ultimately, many, if not most of them, will develop diabetes. And so the screening recommendations are starting at age 10, and that screening test should not be an A1C because it's not very sensitive. You can have a normal A1C, but still have diabetes in this population because of a variety of reasons that A1C is not so accurate, which we'll talk about a little bit later. So for these individuals, an oral glucose tolerance test is recommended. And then to follow those individuals yearly, and then once they're diagnosed with diabetes, the risk of complications are very low at less than 5 years after diabetes. So wait 5 years, but then start screening for eye disease and kidney disease, et cetera. So that was a whole bunch about screening. And now I'm going to move into cardiovascular risk reduction. And here, this section, we actually worked with the American College of Cardiology. And so this is a co-endorsed set of recommendations by the American Diabetes Association and the American College of Cardiology. And I understand we have some cardiologists in the audience, as well as primary care folks for managing all of these types of conditions. So first, recommendation on blood pressure goal less than 130/80, if that can be, of course, done safely. And then the big changes, and this was actually last year, but it's important enough that I wanted to stress it again. So if someone has diabetes and established cardiovascular disease, the goal for LDL cholesterol is significantly lower. And I apologize, I don't have the millimolar numbers here, but milligrams per deciliter, it's less than 55. It used to be 70, but it's been lowered now to 55, so significantly lower. And many of these individuals, despite high-dose statin, may not be able to reach that goal. And there are studies both with ezetimibe and PCSK9 inhibitors, some of the PCSK9 inhibitors, that those agents, when added to high-dose statin, can also be useful in this population. And often it's going to be necessary to get to that low LDL cholesterol level. What about people with diabetes, but they've not had a heart attack yet? What about those individuals, but they are at high risk, and what should their goal be? And here again, for those in the age of 40 to 75, if they're at high risk, the goal LDL cholesterol, again, I apologize, in milligrams per deciliter, is less than 70. It used to be 100, but that's been lowered to 70 based on clinical trials showing their benefit. So less than 70. And then here, in the guidelines, you'll see the language is very purposeful. Whereas in the last case, they should be offered ezetimibe or PCSK9 inhibitors. Here, it may be reasonable. The evidence is not as strong for these agents of PCSK9 and ezetimibe in this population, but it may be reasonable to add that to get to that lower LDL cholesterol. So again, lower LDL cholesterol than what we previously thought. And then there's a whole new section based on a recently published consensus report around heart failure. So it turns out people with diabetes are at much higher risk for developing heart failure. The idea is to be able to catch these individuals early before they have significant disease. And that's why the recommendations are to screen these individuals who are at high risk for heart failure with a BNP test. That can identify a group that if BNP is elevated, the second set of recommendations is that they should have an echo to see if they actually have structural disease and are in stage B, so that you can prevent people from going into stage C heart failure, which is symptomatic heart failure. The next set of cardiovascular risk reduction involves peripheral arterial disease. So that's one of the reasons for amputation. And again, I don't know the data in Canada, but I'm going to guess it's parallel. So most diabetes complications have declined over the last several years, but amputation is one of the few complications that's actually increasing. And so that's part of what's driven behind these new set of recommendations. And the recommendations that are, if an individual is over the age of 50 and has any microvascular complications of diabetes, retinopathy, nephropathy, neuropathy, or they have known foot complications, those individuals should be screened with an anchial-brachial index to be able to identify high-risk individuals to maximize risk reduction. And so all of these recommendations, by the way, have a sort of grading level of evidence. Evidence A is the strongest evidence, which is what you see here. That's based on large RCTs or multiple smaller RCT, randomized controlled trials. The second recommendation is level B, a little less strong, and that's really for anyone having 10 years of diabetes, and largely for people with type 2, to be screened with an anchial-brachial index. And one of the things I'll just mention about the standards of care is that they are often used, not only are they important guidelines for clinicians to use in terms of care, but they're also looked at by payers. Certainly in the US, that's been very much the case. And mindful as these are being developed to things that may not be covered currently often become covered because they've been in the standards of care. And we've seen that over my 4 years at ADA. We've had the opportunity to meet with coverage payers in the US to push based on the standards of care and be successful in coverage for things. So this is an area that we hope to see progress in terms of coverage for anchial-brachial index. The other important area of cardiovascular disease is heart failure, and now there's really a wonderful grade A evidence, large randomized controlled trials that SGLT2 inhibitors are effective in heart failure in preserved ejection fraction and reduced ejection fraction. And I'm sure for our cardiology colleagues in the audience, these medications have really become mainstay therapy for the management of heart failure. not only in people with diabetes, but those without diabetes as well. And really, it's been a wonderful sort of story of accidental discovery, largely, of the benefits of these drugs in heart failure. I want to take a moment to just review briefly chronic kidney disease. Of course, diabetes is the leading cause of kidney failure, and a schematic that sort of puts together the different data out there in terms of how to manage these individuals with chronic kidney disease. At the top are the important lifestyle considerations, a healthy diet, exercise, smoking cessation, and the importance of weight management. And then the next level is sort of the first line of sort of considerations, SGLT2 inhibitors, as long as GFR is greater than 20, so you can use them at a relatively low glomerular filtration rate. Metformin can also be used down to a GFR of 30, so that's an important reminder. The importance of ACE and or ARB, ACE or ARB inhibition, RAS blockade, and then statin therapy. And then the next level down is the use of GLP-1 receptor agonists that have also been shown to be beneficial, and then mineralocorticoid receptor antagonists if there is albuminuria. We talked about screening. We talked about cardiovascular risk reduction. And now I want to move into obesity therapy. And this is the chapter that has been in the standards of care for, the last decade or so. But certainly this year, it's evolved even further. The first is, how do we measure for obesity? And body mass index still is an important measure, but it's no longer sufficient to really describe the situation. And now the recommendations are looking at waist circumference or waist to hip circumference. It should be done at least annually. And really important that this should be done in a private setting so that there's ensured privacy. If you talk to people living with obesity, there is a lot of stigma associated with it. And that's why it's important to provide that privacy so that you can do that appropriately. And that's a call out for clinicians everywhere. People are often successful in losing weight through a variety of lifestyle measures, but weight maintenance tends to be more challenging. And the literature on this has really expanded significantly. We know a lot about what works for weight maintenance. Some sort of monthly contact or support could be someone on the clinical team. It could also be virtually. It could also be through digital health solutions are effective. Some weekly weighing and some way of self-monitoring of behavior could be food records, etc. And interestingly, it seems that for losing weight, dietary changes are most effective. For maintaining weight, physical activity tends to be the most effective. And physical activity recommendation you can see are 200 to 300 minutes per week versus the standard recommendations of 150. So it takes more physical activity for weight maintenance than the typical recommendations. When it comes to pharmacological therapy, it was important to state, based on randomized controlled trial evidence, again, you can see this is level A evidence, that semaglutide and tirzepatide are the most effective therapies and therefore recommended as first-line medication. I understand in Quebec and largely in Canada, these are much more accessible than they are in the US, and that's been a big source of challenge in the US of advocacy to ensure that there's greater access to treatment because these really have been very effective. I thought it's also a good moment to just zoom out a little bit and think about the big picture, the pharmacological management of type 2 diabetes. So I'm just going to take a little segue for 5 minutes and talk about that. So The general principles are, when we're thinking about managing type 2 diabetes pharmacologically, there are really sort of three things to think about when choosing therapy. And the first is, what comorbidity does the individual have, cardiorenal or heart failure? And I'll show you this schematically in a moment. Then the second consideration is weight management. Is this something that is important for this individual? And then the third, or the other one, is around efficacy. So what is their glucose levels, and what do I need to get them to? And I need to pick an agent that will get me to that goal A1C, for example. And then the final thing to mention is this idea of therapeutic inertia, and that's the observation that patient comes in, A1C is elevated above goal, and they leave without any change in therapy. And there can be lots of reasons for this. There are provider issues, there are patient issues, there are payer issues, there are system issues, but trying to address that in some way, because studies have demonstrated that typically a patient will be out of A1C range for an average of 2 or more years before there's a therapeutic change. And that obviously puts them at risk for complications for quite some time. Okay, this is the big algorithm. I apologize for its complexity, and I'm going to blow it up so you can actually read some of it. But what I want you to see is, at the high level, there's sort of two halves. There's the left side, and that's the comorbidity side, and then there's the right side. So that everything's sort of that green area, and then that yellowish area. And I'm going to blow this up in a moment so you can see the left side, what I'm talking about, on both sides, actually. So at the very top of this algorithm is the importance of healthy lifestyle. That's true throughout their journey with diabetes. The importance of diabetes self-management education and support provided by someone on the team. That's critically important. It's evidence-based. It's been shown to reduce A1C. And then social determinants of health, assessing for them and addressing them. An issue, really gargantuan issue in the US, but I suspect still here in Quebec, you have some of these issues that are important to assess. Then really, on the left side, it is, what are the comorbidities that these individuals have? And in essence, regardless of their A1C, regardless of whether they're on metformin or not, one should use therapy to address that comorbidity. And in the far left, if they have atherosclerotic cardiovascular disease, GLP-1, which has been shown to reduce cardiovascular disease in large randomized controlled trials. True also for people at high risk. SGLT2 inhibitors may have a role here as well. If they have heart failure, congestive heart failure, SGLT2 inhibitor, regardless of their A1C. And if they have chronic kidney disease, SGLT2 inhibitor, or now we have some good evidence this summer from the FLOW trial of GLP-1 receptor agonists being effective in this group. So that's therapy based on comorbidity. Then the second area is in the mustard sort of color is what about their efficacy and goal A1C? How far are they from goal? And this is where there's a table that sort of shows the relative efficacy of different treatments. And so, for example, DPP-4 inhibitors tend to be relatively mild and really have a small effect on A1C, 0.5 or less. So if somebody is 2 points above, that's not going to be a good choice because you're not going to get them to goal. So getting to goal A1C based on efficacy of therapy. And then the third on the far right here in this diagram is weight management. Should you consider therapy for weight management, avoiding sulfonylureas, for example, considering a GLP-1 receptor agonist or dual agonist or SGLT2 inhibitors or metformin. So that's the mindset of therapy. And then one other call out is, often people ultimately end up on insulin. They'll be on a basal insulin. Before adding mealtime prandial insulin, the individual should already be on a GLP-1 receptor agonist. And that's based on data that there's less hypoglycemia and less weight gain adding a GLP-1 than mealtime insulin. So we talked about screening, type 1 diabetes, pancreatitis, diagnosing type 1 versus type 2. We talked about cardiovascular risk reduction, lower LDL cholesterol, screening peripheral arterial disease, use SGLT2 inhibitors, screening for heart failure, obesity we just covered, and I'm going to finish up technology, and then I'm going to talk a little bit about that journey from knowledge to action. So first is to think about the utility of A1C and some of its limitations. So there are known limitations in individuals that have blood disorders that may have high turnover. There seem to be some racial differences in A1C values. And those are one set of limitations, but another one is just the simple understanding that you can have an A1C that is good at, for example, 6.8 by having glucose levels that vary very little, like this, or that vary quite a lot. And you can imagine it would be much better to be like this than to be like that, because you're getting lots of hypoglycemia. And so A1C is helpful, but it doesn't give the full picture. And with the availability of continuous glucose monitors, that's really changed the way we look at the management of glucose for people with diabetes. So first, the recommendations, and they're really quite strong based on robust data, is that essentially anybody with diabetes, regardless of age, so children, adults, older adults, who are on insulin, any type, basal insulin, multi-dose insulin, insulin pump, should be offered a continuous glucose monitor. And my understanding is that there's good coverage here in Canada for that, which is great. And I'll tell you, I still see patients at my former institution, Joslin, and the biggest aha for most people with diabetes is getting a continuous glucose monitor. And once they get used to it, not having it for one day is like, they don't know how they can live without it. It's sort of like us living without our phones. And at the same time, there's emerging evidence about the use of for individuals not on insulin, where it can give feedback on behavior that can be very helpful. And now there are actually continuous glucose monitors available over the counter that are being used, and it'll be interesting to follow that world of people without diabetes that are using CGMs, continuous glucose monitors. I want to just show you what the tracings look like if you're not familiar with a continuous glucose monitor. And this is a standardized report, AGP, that is generated by the different continuous glucose monitors. In the upper left here, you can see a grid, and this is information that the patients can see as well. And it sort of has the time in range, that green area, 70 to 180. And then it divides it into two areas above and very much above, and below and very much below. And there are specific recommendations, the amount of time that should be spent there. On the right-hand side, these are typically 14-day or 10-day averages. There's a mean glucose, which is helpful. And based on that mean glucose, if you extrapolated that to an A1C, that's what the GMI is. Remember that an A1C is a 3-month average. This is only 2 weeks of data or 10 days of data that you're looking at. So you need to be mindful of that. And then probably the most helpful that I go to right away is this midnight to midnight measure of glucose. The dark line is the average, and you can see the plus or minus variation of glucose. So quickly, you can look at this pattern and say there's a lot of variation of glucose, and you may ask an individual with diabetes why that might be. And most importantly, in red, you can see overnight there's hypoglycemia for several hours, and the patient might not even be aware of this. And so right away, this individual, we need to, if they're on insulin, reduce the nighttime insulin, reduce that hypoglycemia. And you can see how this becomes such a valuable tool for healthcare professionals, but also for people living with diabetes that can self-adjust based on this type of data. So we covered the 4 areas of what's new. Your knowledge hopefully has been expanded in the world of diabetes, and now thinking about how do we take that knowledge and move that to action. And so this is the path, over the last 4 years, I mentioned being at the American Diabetes Association, that we've taken, and I think it's a very useful way to think about this. So really, the knowledge is generated through research, and there's some great research going on here at McGill, looking at a number of factors that ultimately will be the things that will influence these guidelines. That research then is taken through an evidence synthesis process, and ultimately then are developed into guidelines. In the case of the ADA, it's the standards of care that I described. But that is more information than most people are going to want or able to absorb. And so there's an abridged version that makes it a lot easier to sort of capture the high points, particularly for primary care providers. But we know that that's not simply enough. And how do we know that? Because we've been publishing the standards of care for many years. And if you look at A1C, at least in the US over the last decade, there's really been no change, despite all the new therapies and new glucose monitors. So we need to move to action. And so part of that is taking that information and providing it in actionable ways to healthcare professionals, and I'll mention what the Institute of Learning is. And then it's really that moving to action, and that's what quality improvement is. It's the science of how to take that and move it into action at the practice site. And the next stage of that is how do you do that quality improvement at scale? And that's this idea of dissemination and implementation science, which over the last decade has really identified a lot of really helpful ways to do that at scale. So I mentioned the Institute of Learning is how to provide continuing education. These are free courses available on the ADA website. They're in a variety of different topics. Think of it as ADA University. You can take any one of these courses. They have different modules in them. They're multimedia. They're engaging. It's not an hour lecture. In fact, the data, as you're probably aware of an hour lecture like this, how influential is it in terms of changing provider behavior? Not much, unfortunately, although we do it anyway. But these short snippets and videos and things like that are more effective. But again, it's moving further to action, and I want to share a little bit of the work that we've been doing over the last year or so, focusing on primary care. And this has been a major shift for the American Diabetes Association, and it's really where I've been sort of focused on the last 20 years or so in the research that I've done over that time, and heard about work around patient-centered medical home was part of that. So why primary care? And that's, to me, it's fairly obvious. It's where the patients are, right? Like in the US, 90% of patients with diabetes get their care from primary care providers. I suspect that's largely true here in Quebec and Canada. I think I saw there are only 587 endocrinologists in all of Canada, and I think 3.7 million people with diabetes. Math does not work, right? They're never going to be able to see all those people. And then that statistic that I shared, that despite all of the new therapies, we've really not advanced patient outcomes significantly. that knowledge is important, but we need to move to action. It's necessary but not sufficient. And there are some proven methodologies that can help primary care, that we can partner with them to drive better outcomes. So big question is, who do you focus on? And this has been a debate for a while, and I'm going to point to this innovation curve on the right. You may have seen this before. This has been around for a while, and it really is sort of how any innovation spreads, even outside of healthcare. There are a small number of early innovators that are always looking for something new, and they try it. That sort of then leads to early adopters. They're ones that, okay, I'm gonna try this. I've heard some buzz around it, and I'm gonna do it. And then it moves down until at the very end of the bell-shaped curve are the laggards, the people that, and you may have met these folks. I'm not going to do it until it's been around for 5 or 10 years, right? So very much thinking about how do we address this at scale nationally if we want to improve primary care? What do we need to do? And the argument is that we go for the early adopters instead of everybody. We have some stuff for everybody, but the concerted effort is on the early adopters. And the early adopters are those that are already used to some of the basics of quality improvement. They have some way of measuring how they're doing and looking at that data to see if they did something different and it improves. They have a way to meet regularly to talk about how to improve. They have some of the basic infrastructure around quality improvement. Working with those individuals, and they're often the leaders in primary care around their health systems, they can then be the ones that spread it more broadly. And that's really been the initiative. And so today, we at the American Diabetes Association, we partner with 2,000 practices, part of a group called DARTnet, which is a consortium of primary care research networks that have been around for a while. We've also recruited an additional 1,000. And then something that George mentioned, the Primary Care Council. So a few years ago, we realized that it's difficult for a specialty organization, or what's viewed as a specialty organization, to drive better care without engaging with the primary care community. Because in the end, primary care providers get their information more likely through their organization. And so we partner with the major primary care organizations in the US to form a council that met frequently to identify priorities and strategy. American College of Physicians, American Academy of Family Physicians, nurse practitioners, the physician assistants, the pharmacists. And we've been making progress to identify what are key implementation steps in primary care. And there'll be a paper coming out soon that is a consensus of all of those organizations. The big goal is, so we're at 3,000, we want to get to 5,000 practices, which would be that 5% of early adopters. And that would be enough, we think, to tip things over. That would be the tipping point. And we'd use dissemination implementation science to take the practices that we know that are highly effective in improving care and bring that to all. To get these practices following those and embedding them, and then they'll spread it more broadly. So that's the big goal. And then my sort of hobby now is to continue to foster this effort and proselytize a bit about that. So I got a chance to, first of all, talk a little bit about the standards of care, what's new around screening, obesity treatment, cardiovascular disease. We talked about technology and continuous glucose monitor data. And finally, I really want to thank you for having me back here at McGill. It's a place close to my heart. I really learned so much here and grew so much as a person. And thank you for having me, and glad to answer questions.
Thanks so much, Dr. Gabbay. That was terrific, and that gives us a lot of things to think about in terms of improving diabetes care. We do have a few minutes for questions. I have some questions here on the chat. Oh, please type the name of the app in the chat. It's ADA Standards of Care. Given the long diagnostic odyssey for genetic diseases and the decreasing costs of molecular testing, would you consider putting molecular testing earlier for younger patients? As regards molecular testing.
Yeah, no, that's interesting. So would you do molecular testing earlier for type 1? I think yes. And I'm going to take this as a question for type 1, but also for type 2. For type 2, I'll start there. We're reasonably good about predicting already. We could be better. The interventions are largely now lifestyle and or metformin. There's probably less of a need there. But I would argue, as we've seen some studies demonstrating that GLP-1 receptor agonists are able to prevent the development of type 2 diabetes, then you might want to be able to identify the highest risk, and that's where molecular testing could be helpful. In the case of type 1, there has been work of markers that are predictive, and they do add to the antibody testing. And as that becomes cheaper, I could see a time where that helps to refine the risk even further, because as the interventions get to be more robust, you probably want to pick, once again, people at highest risk to be able to intervene.
So along those lines, I have a question regarding the screening of type 1 that you began with, which is very interesting and new for us. Of course, we don't have the means to do that right now, but I'm interested in whether you think this should be a population-based screening or something that we should target only the relatives, given the genetics, but also the variability in new type 1s, which are mostly not in families with family history.
That's a great question. So you're putting me on the spot here, which is good. There are a couple of ways to look at this. I think that on one level you could say, yes, let's screen the population. My concern there is, is it cost effective? And there really haven't been good studies to look at that yet, because again, when you think of a societal cost of doing something, you've got to weigh that as whether it's cost effective. How will you manage all of those individuals that are antibody positive? Because I can tell you that when individuals are identified as antibody positive, and typically this is going to be in primary care, there's a fair amount of anxiety, and there needs to be some counseling that occurs to help guide them. Because many of them will probably not even know what type 1 diabetes is, and it's gonna be. So I think if you build the appropriate resources around that effort, that can be helpful. I think the easier and initial stage is, and the recommendations are for first degree relatives who do have a significantly higher risk. So if you think of a hierarchy, it would be those first degree relatives, highest risk. Those with other autoimmune diseases might be the next group, and then potentially the general population.
Great, thanks. I guess it would be important to have a better therapy also to make it cost effective, as you mentioned. Nadia.
Thank you very much. Wonderful lecture. I am one of those heart failure cardiologists that has gone into the world of diabetes, and we're very happy. We see great success with the SGLT2 inhibitors. One of the issues that comes up often in when we meet as cardiologists is obviously the lack of knowledge of some of these medications in diabetes, and the fear of hypoglycemia, especially when somebody comes in already on a medication for their type 2 diabetes. What could you say to cardiologists about assuaging our fear of putting our patients in a dangerous situation of hypoglycemia?
Yeah, very briefly. So the question relates to the use of SGLT2 inhibitors in patients with congestive heart failure and the risk of hypoglycemia. I guess in those with or without diabetes.
Yeah, already have diabetes, we're already on other medications.
Right. The concern really is in people with diabetes or on other medications and the hypoglycemia risk. And I think it's great that you asked that question because I think this is super common concern. And I think there's some general recommendations because, I appreciate in the same way that us as endocrinologists are now managing heart failure and thinking about heart failure. And we didn't really think about that much. The cardiologists are now needing to think about these new areas as well. A couple of sort of general guidelines. First would be looking at their A1C. If their A1C is elevated, then you really have little to worry about adding an SGLT2 inhibitor in terms of causing hypoglycemia. So someone with an A1C of 9, you have like almost zero concern. Someone with an 8, maybe. Okay, so let's start with that group. If they're on insulin and you're sort of concerned and there's sort of the do no harm, you may reduce the insulin dose and then have that retitrated up. And that's where partnering with primary care provider or endocrinologist can be helpful. On individuals not on insulin, no real concerns unless they're on a sulfonylurea. And if they're on a sulfonylurea, you may lower that dose just to reduce the risk, although again, the risk is not terribly high. And the other recommendation would be if they are on insulin, really the standard of care is that they're on a continuous glucose monitor. And that may not be something that you have to prescribe, but that should be something to alert whoever their primary manager of diabetes is.
Great. Well, we're at the hour. So I think Dr. Gabbay is here if people would like to ask more questions. I'd like to thank you again for a terrific lecture and updating us on diabetes care, and wish everybody a good afternoon. Thank you.